it right. So without further ado, we'll get started. I'd like to introduce Melissa Peterson. She's the clinics manager at Columbia County Health Systems, and she has been working diligently at Columbia County Health Systems for a number of years since, let's see, what was the first year that you started there?
2019.
19.
Yeah.
So she started as a population health nurse and then has worked as a clinic manager since 2021. And I wanted to have you explain a little bit more about, like, well, what clinics are you manager of? What does that look like? Because that makes it a little more clear for our listeners. So can you explain? Yeah, thanks.
So I actually have kind of that built into my introduction. So I can either start or I can take that piece out if you'd like.
No, leave it and we'll pause and wait for you to say that as part of your presentation. Melissa is known for her passion and commitment towards the implementation of programs and practices that improve health outcomes within the community. I think a simpler way to knowing Melissa is just knowing she cares so much about the people in her community and wants to do things that really help. And it's not only Melissa, but it's also like Columbia County Health System. When you're there, you really feel it, that they really want to care for their community. Melissa is a registered nurse with a Bachelor of Science degree in equine studies, and has worked for Columbia County since 2019. She's currently enrolled in WSU's Master's in Healthcare Administration and Leadership program and is expecting to graduate in December. So
can't wait for that.
Yes, but we're benefiting from her studies today because her presentation will reflect some of the work that she's been doing as part of her master's program. So I will hand it over to Melissa.
All right. Awesome. So this is the second time that I've presented this. This initially was my capstone project, and I have added more to it to make it more appropriate for this audience. Initially, when I presented it, it was for a very basic generic audience, and I wanted to make sure, that sounded wrong, but non-healthcare audience, and now I'm presenting to more of a healthcare audience, so I added a few more details that we'll talk about today. I'm going to go ahead and try to figure out how to start this presentation. Give me just a second here. Maybe. There we go. Okay, so for my capstone project, I really wanted to dive into the topic of social determinants of health. As a rural health district, we're constantly bombarded with these issues that I'll talk about in a little bit. But I really wanted to figure out how we could streamline our referral program and how we could track and help our patients. So just a little bit of a background about Columbia County Health System, in case some of you guys don't know. Columbia County is located in Southeast Washington State. We make up about 869 square miles with a population of about 4,025. I think someone might need to mute.
Yeah, I was going to say, can we all make sure we're muted? There's some background noise coming in.
Yeah, he said, Albo said, both, he said, whoever's walking will feel that.
All right, I'll keep going. So population of about 4,025 individuals. 29% of our population is over 65 years old. So we are one of the oldest counties, or oldest aging counties in the state. The state average is at about 17.5%. So almost double what the state average is. So we have a large group of our patients that are 65 and older with comorbidities and also social determinant needs that that we haven't really been able to address. So we have a 13% poverty rate. State average is 10%, so we're above that state average. Some fun facts that Shane shared with me that I like to share with others is that Shane is our CEO, is that we are the 6th largest wheat producing county in the United States, and 26% of wind energy is produced in Columbia County. So obviously we play a huge role in not only agricultural, but also energy systems as well. So we know that there are a lot of farmers and in our area, and we have a lot of generational issues happening in our community as well. So a little bit about the ambulatory side of Columbia County Health System, which is kind of the clinical side. We are designated rural health clinics. We have 2 rural health clinics, one in Weedsburg and one in Dayton, and then 1 fee-for-service clinic in College Place. So 3 clinics are primary care clinics. And then we also have an integrated dental clinic that's attached to our Dayton primary clinic office. We have integrated behavioral health. We have a transportation department, and then we have an outpatient population health team. And I'll go over a little bit about that here in a couple of slides. But that gives you an idea of what our county looks like and what our health system looks like.
And Melissa, did you have slides for that, or is that just background information?
That's just background information.
Okay, I just wanted to double check because sometimes when I'm presenting, my slides aren't advancing for some reason. So great, you're all set.
Yeah. Today, I will be focusing mainly on our population health team and social determinants. So that background kind of gives you an idea of what we are as a whole. But I really want to dive into more of what our population health team does and how we're learning how to address social determinants, because of course we're constantly learning what our community needs, not only what our community needs, but how we can help them. So our agenda today is just to go over like our original plan, the events that happened, and then the lessons that are learned. I wanted to share a personal story. It's not an uncommon story. I probably could go on and on with different things that our population health team has done for our community. But this is just one of our most recent examples and recent success stories. We had a patient who had dementia that was referred to our population health program in 2024, refused all contact from us, so was outreached by our palliative care nurse and our community health worker, would not let anyone into the home, would not speak to any of us. The husband at the time was overwhelmed, but also wanted to respect his wife's wishes, which I think we can all understand. We left our information for them, but also stopped making contact out of respect, and just kind of left it at, hey, you know what, give us a call if you ever do need our help. We will, we're always going to be here for you. About 6 months later, the husband called and reached out to us and said that he could not manage his wife's symptoms at home anymore by himself. Obviously, this is an aging couple. And so we were able to work with him on developing basically kind of like a script as to how we could be able to get into the home to try to help and form a relationship with his wife whose dementia was advancing, which any of you that have experience with patients with dementia, you know that can be an ongoing and a different everyday kind of a challenge. And so we knew that maybe what worked one day wouldn't work the next day. So we had to be very strategic about how we not only supported the husband, but also how we supported his wife. And so we developed a plan and were able to get into the home. So our community health worker and palliative care nurse were able to get into the home, assess the situation. I shouldn't say we all know, but we here know that getting into the home is the first step in really being able to evaluate patient situation, patient social determinants, and really what's going on and what's affecting their healthcare. So we were able to get into the home, talk with the husband, talk with his wife. Our nurse practitioner actually made a house call and came into the home as well to go over our medications, look at different options for caring for someone with dementia with the husband. it was determined that at that time that it was too much for him to be able to handle alone, and having a home care aide would not be sufficient. So oftentimes when patients are approved for home care aides, they only get a few hours a week, and her dementia was advancing to the point that she needed 24-hour care. So if anyone has ever experienced trying to coordinate healthcare with dementia, you know that it's a very complex issue, and it can be very overwhelming because often you don't have time to do that in between. How do I find this? Who do I call? How do I even think about going into memory care? Is that a good option? Where are my options? What happens next? And so for the husband, that was extremely overwhelming, understandably. Our whole entire team, and when I say whole entire team, I mean social worker, community health worker, palliative care nurse, and nurse practitioner, all work together with the husband and aging and long-term care to get memory care placement found for his wife that was local enough where he could visit, so he wasn't missing out on seeing her, and she wasn't missing out on seeing him. And also, this happened within about 6 weeks of initial contact. So now her husband, this is going to sound odd, but her husband is back to riding his motorcycle, which he could not do before. He can ride his motorcycle to memory care to see her. And just a little side caveat, because this is how cool our palliative care team is, in my opinion. They had a cat who had been adopted, and one of our nurses actually adopted the cat from them, and the cat is now living with them. So success story, also crazy cat lady story, but I just wanted to give you guys an idea of the work that we do and how it directly impacts our patients. Our mission really is to see people as human beings and not just a number. Of course, in healthcare, we have to focus on numbers sometimes, right? Like that's a big thing. That's how we see progress. That's how we measure things. But at the end of the day, it's a husband who's overwhelmed because his wife has dementia and he hasn't slept and he's barely eaten and he's worried and he's scared. And we helped him overcome those things. So that's my quick brag moment for everybody. But we'll move on now a little bit. So those stories, I guess, are one of, I'm just going to speak candidly for a minute. Those type of stories that I hear every week in our population health meetings are the reason why this is such a passion of mine. And you're probably going to hear me fumble over my words a little bit and talk too long or too fast. But it's because I'm really passionate about this topic, and I feel that it's something that we all should be focusing on. And we all should be helping each other to figure out how to focus on it because it is such a complex issue. So main focus, exploring primary care's role in health disparities and social determinants of health. Obviously, let's make it personal. It's personal for me. It's personal for most of you that are working in healthcare. We know studies have shown that, and a lot of you guys know this, that health is more than healthcare, right? So 40% is socioeconomic factors. These are things like education, job status, family, social support, income, and safety. 10% is physical environment, so where you live, how much pollution is around where you live. In a farming community, we have things like chemical spray or, dust, especially during harvest. 30% is health behavior, so tobacco, alcohol, drug use, diet, exercise, and sexual activity. So anytime you're seeing, like a history of alcoholism, drug use, drug abuse, that directly impacts your social determinant. And then 20% is healthcare or access to quality healthcare. In a rural community where we're the only healthcare system in 40 miles, we are it. And so ensuring that our community has access to us is vitally important. Which means if you add all this up, simple math, right? 80% of health is outside the doctor's office. Let that sink in for a second, because that means we can only control maybe 20% of somebody's health. And so how do we tackle that? That's so big. We can't fix everything as a healthcare system, right? How do we work together in order to ensure that we can reach maybe a portion of the socioeconomic factors, a portion of the physical environment or health behaviors to where our impact is more than 20% on our community? Just to give you a little idea on some national statistics, 1.48 million are currently homeless in the United States. 3.6 million cannot access healthcare due to lack of transportation. You're going to see a little bit more about that later. 42 million face hunger, and 12.7% of households are food insecure. Currently in the United States, only 29% of hospital systems are screening all patients for social determinants of health. That means we have let me see, quick math, 71% room for improvement to identify what factors are impacting our patients' health and how we can help them overcome some of those disparities so that they can focus on things like diabetes, congestive heart failure, hypertension, hyperthyroidism. We could go on forever and ever. You think about the fact that if somebody can't afford their utility bill, do you think they're going to care about their insulin or, their inhaler? Try to get an inhaler covered by insurance right now. It's a nightmare. So, how can we help to intervene so that we can take the utility bill off the table so that they can focus on their insulin, so that they can be healthier? I forgot to mention earlier because I'm kind of nervous, but if you guys have questions at any time, please just shout out. I can only see my screen. I can't see if somebody raises their hand. So if I miss something or you want clarification, please let me know.
Thanks for that, Melissa. I'll watch the chat for you too.
Oh, that would be great. Thank you so much. All right, so here's our original plan. So the first thing that we needed to do was to assess our current resources and workflows. I've only identified some of our community resources here. We are very small, so we don't have as many resources as, say, Tri-Cities or Spokane or Lewiston. So the list isn't very long, but we do utilize what we have. We know what we have and we know what we've been doing, right? So we knew that we had an incredible population health program with the most compassionate, empathetic human beings that I've probably ever been around. We know that it's one of a kind. And we also know that we've worked really hard to grow that. So I want to kind of take a step back here. I'm going to talk about our population health program, and then I'm going to tell you that when I say all of these things, it's probably going to be like, that's great that you have that, but how do I get that? And I'll tell you right now that it didn't start like this. What you see on the screen, which are the bullets underneath population health program, that's not how it started. It started with one palliative care nurse with no reimbursement. We didn't get any money for her work, no structure. It was go out and help people in the community, and let's try to reduce some ER visits. That was our main goal. Let's reduce ED utilization. Good goal, right? We want to do that. But over the last 4 years, it's grown into so much more of that, because as we keep diving deeper and deeper into our community, we keep seeing the need grow and grow and grow. And I'm very thankful that we have an executive team that allows us to be creative when it comes to trying to impact patient outcomes, because that has allowed us to grow this program. But it started with just one nurse, and it took a while to get to the point that it's at today. We started with one palliative care nurse that grew to a chronic care management nurse. So that's someone who is working with patients that have 2 or more chronic conditions over the phone, doing care coordination, calling and checking in, seeing if they need anything, helping them make doctor's appointments, helping them reach out to their specialists. And then a community health worker who has his master's degree. So he's kind of our kind of our go-to guy. And then obviously the palliative care nurse. And then we added a palliative care nurse because the first one was so overwhelmed with patients that we needed help. And then we added a provider champion. I think this was probably the biggest boost in our population health team, was having that provider champion. And with her permission, I'll share a little bit of her story since I know I have a little more time. But she was at the point of burnout in primary care. She was one of our primary care providers and one of the most intelligent women that I've ever been around. But she was ready to be done because we were in the middle of COVID. And as any of you who worked during COVID know, that burnout is real, and it was not an easy time for any of us in healthcare. And fortunately, we were able to kind of shift her role, and we identified that we needed a leader in our population health team. Management director couldn't necessarily take the time, nor did we have the time to really be available to those individuals that were out in the field that needed those resources pretty quickly if they, had a question about a wound or a medication or a social issue, or, hey, I've got a suicidal patient, what do I do? And so her role has been instrumental in helping the rest of our team. And she acts as not only a resource, but an advocate for our patients. When our providers in the clinics are too overwhelmed with patients for the day, she can step in and help with these complex patients. So that's been an amazing addition. And then we added diabetic education, and an administrative assistant, another community health worker. So now we are an 8-person team, and everyone is out working in the field and or in the office, trying to really address not only the social determinant needs, but also the healthcare needs of our community. Any questions so far? Okay. So our population health program is made up of palliative care. So palliative care in our setting looks a little bit different than inpatient palliative care. So palliative care is really intended to decrease ED utilization, but also allow our patients to age in the home independently. So we have nurses that are out in their cars, literally with like a box of supplies in their trunk, and their computer, and they go out and visit patients in their home, education, med reconciliation, wound care, IV antibiotics, you name it, any nurse related skill they can do in the home that's safe, and then they will. We have chronic care management, talked about that already, community health workers, Partners Improving Patient Health. That's a disease management grant that we got through HRSA. So that's been a 4-year process where we identify patients that have COPD and or cardiovascular disease, and we've developed workflows to help care for them and help them care for themselves. So really a lot of education, a lot of goals around independent living with these chronic diseases, and then diabetic education. So our resources that we mainly work with are the health department, Project Timothy, Food Bank, Greater Health Now. So we'll talk a little bit more about that since they're on the call today. And then also ALTC, which was not mentioned here. So I apologize for that. So this was what we were currently doing. It was there, you get a referral from a primary care provider to the population health program, and then we kind of figure out what to do with the patient. But that wasn't really helping us identify the social needs of the patient. And so we wanted to know, how can we improve? How can we support our community and our population health team at the same time? And how can we identify social needs outside of, this patient has congestive heart failure and is calling into the clinic a lot with questions. Let's get them connected with population health so that they can really help with care coordination. We wanted to take it a step further and streamline the process to see if it could be achieved, I guess, essentially. So hold on 1 second. All right. So our priorities were screening. So we wanted to see where we were at, get a baseline, and assess the need. And I'll talk about more about screening here in a minute. In our EMR, I have some screenshots for you guys. We wanted to assess the need, right? Like, how can we implement interventions or design interventions if we don't even know what the need is? And then we needed to streamline that referral process, create a process from provider office to the population health team. What would that look like? How would a positive screen for SDOH in the clinics get to the population health team? And then what would they do with it after that, right? Like how would it be assessed? What's the follow-up? How do we close that loop? And then create relationships and with our community partners and develop a referral process. So specifically, our focus was on the Greater Health Now Hub portal for increased access. We know that our resources here in Columbia County are really limited, specifically around housing. And so we wanted to really develop that relationship with Greater Health Now so that we could utilize their hub portal and hopefully help our patients find some of those resources and be connected to them when we were unable to provide them for them. All right, so the first thing that you always have to do after you identify what you want to do is problem solve, right? That's the funnest part. The biggest thing I think that any of us can talk about when it comes to healthcare and problem solving is your electronic health record. This was probably the heaviest pull in this whole entire process. So a little history on when I say screening not streamlined here in that first bullet point under EMR. I want to talk a little bit about the prepare form. I hope that most of you are familiar with the prepare form, but the prepare form is a nationally standardized SDOH screening tool. So it's literally a piece of paper that has questions on it that address some social determinant need. And it's intended to give to the patient to have them fill out and then give back to their provider. So we're going to talk a little bit about that now. Initially, we started with the prepare form in 2020. This was utilized, but it didn't go anywhere. So let's say a patient screened positive for risk of homelessness. We clicked the button in the EMR, but we didn't do anything about it. It didn't go anywhere. No one identified it. The provider might say something to them, but we didn't have any streamlined process. We were just able to say, yep, we're screening with the prepare form. That's great if you want to click a box for data, but it doesn't help our patients, right? So in 2023, we switched EMRs and the prepare form was not part of the new system. So we had to design our own. We worked with acute care to streamline the screening tool. We chose something smaller than the prepare form. If anyone has seen the prepare form, I think it's 20 or 25 questions. If I'm remembering correctly, it's been a while. But I want to identify screening fatigue with patients. So it's really easy to say, fill out these 5 forms when you check in with for your provider appointment. That's a lot. What if you can't read? What if you didn't bring your readers? What if you are sick? And so we knew that the prepare form was cumbersome from when we had used it prior. We knew that we had a higher probability of patients declining to fill it out because it was so cumbersome. And I'm not speaking necessarily badly about the form, but it does ask like income, veteran status, like things that the patients were like, I don't want to answer this. So
Melissa, I want to drive that point home a little bit more because I think it's really important for people to understand. Like 5 forms. I mean, so that's in addition to what's your name, your birthday, if you want to share with us, your race, ethnicity, language. Is this your correct phone number? You get through that. And then it's like, oh, here, do this PHQ9. Are you feeling depressed? Are you feeling, it's like, oh, okay, GAD7, because those are all things that Columbia County, they do a lot. And so, but as an individual that walks in and they go, oh, here's your prepare form. I think it's so important for us as people involved in trying to help other people that what we ask of them, we have to be so careful because we need to look at what it looks like in real time. So I know that's kind of one of my soapboxes is like, people will say, well, let's just add this. I'm like, no, that can't be done, because it's just so hard to get to really, it sounds good as an idea, but in life, it's very difficult. And then the real problem is that your data is going to not be valid, because if the social determinant screening is their fifth form, they're not going to care anymore. They're going to say, yeah, nope, I'm good. So I just guess, sorry, Melissa, that's one of my things. So I just wanted to drive that home a little bit with all of us as we think about our processes and things, because a lot of you guys are breaking new ground and trying to figure out how to do this. And so I'm speaking to the choir, but couldn't resist.
No, I think screening fatigue is a real thing. That's one of the reasons why, and I'm jumping ahead here, but we screen once per year unless they screen positive. So that's part of our chart prep, is that we're only screening for this once a year so that we don't encounter that screening fatigue where patients are so used to the questions they don't even read them anymore. Because then your data is skewed, and that's not the point of what we're trying to do here, All right, so we streamlined the screening tool, and you can see that here. So it's really simple. It's like 7 questions, and they're pretty basic questions. I think the most important is the very bottom where it says, does the patient want assistance with any of the above, right? So maybe you have gone without enough food to eat for a couple weeks in between jobs. And so you say yes to that, but you're good now and you don't need help with that. So you can say yes or no there. And that is really a opportunity area for the provider to have a conversation with the patient, depending on the answer to that question. So I really like that last question a lot. Another issue was the registries weren't working. We're going to go over registries here in a minute. But trying to get this data, whether you answered yes or no to any of these questions on the screen, to flow into a registry, which is a list that basically coordinates all the patients that have answered yes or no to certain questions, trying to get all of that data to go over to that patient list so that we could actually identify the people that needed our help, took approximately 6 months. So it's not, when I say that the EMR was the heaviest pull, I'm not lying. And we're talking hours a week at trying to get this kind of stuff done. And then
I would say
streamlining.
well done to Columbia County, because you guys don't give up on it. So I don't know if Minnie's on the call, but good job, Minnie. There's just, 6 months is pretty short, really, for getting a change in an EMR. So I commend you.
And that's like one of the many changes that we're making at the same time. So yes, good job, Minnie. You're an amazing human being for sure. And then streamlining that referral process. So this was actually pretty easy. A conversation between me and the provider champion on figuring out how we were going to take those referrals from providers. So if a patient screens positive and they say, yes, I want assistance with the above, I'm going to show you in the next slide how that initiates a referral to the population health team. And then the population health team will actually get that referral, process it themselves. So it doesn't go through a referral department as far as, anything except for sending it along. And then we're able to review the chart. A provider reviews the chart and identifies, and we can reach out to the patient and identify what needs they have. And then with community resources, lack of communication to no communication. So reaching out via email, reaching out via phone. Sometimes I would get a response, sometimes I wouldn't. No judgment there. Like, everyone is busy. Sometimes volunteer ran community resources. The people change, so they don't know who I am, or they don't know who Dawn is, or anything like that. So that's just a challenge that I don't think is going to go away. I think we just have to keep trying. Limited services, so limited availability of our resources. And then the Greater Health Now timeline for the hub accessibility. This is from the very beginning. When I first started, it wasn't quite up and operational yet. So that's why that's in there. And now I believe we're in the process of maybe starting our first referral. So that's exciting. And then just system issues, right? Like, how do we know if we make a referral if it's going to be addressed, how do we follow that patient? So really figuring out how to do that. And one of the things that we identified was that the community health worker can be that in-between person that can connect the patient with a resource and can follow up. So it's just organization and workflow development on the community health worker role that can help kind of close that loop for this issue. All right. So at Laurel's advice, I put in some registry examples so you guys could kind of see what we track and how we track it. So on the screening tool that you saw a little bit about the questions that we're asking. And so this shows us, and I took off all the health information, but the social determinant of health, it tells us when it was last screened, how many days ago. It also tells us if any health related social needs were addressed and or documented even in the past. So we know we haven't been doing this for that long, but we also know that some providers, whether it was in the ER or in ambulatory side, may have clicked one of these boxes in a different part of the EMR, because of course there's multiple areas. And then if the patient requested assistance, we're going to ignore these two for now. Patient requested assistance, you can see that yes, they did, or no, they didn't. So that allows us to kind of see, okay, yes, they do want help. We're going to filter by yeses and nos so that we can identify those ones that say yes, so that we can outreach to them sooner. We have a 3-day turnaround for outreach to patients when we get referrals. And then here is where we can filter and track what the social determinant needs are. So these directly relate to our screening tool. You can see here that there are some people that have multiple positive screenings. And then we're also able to click on these. I can't do this because it's a screenshot, but we're able to click on these and see if there's any comments that were made. So that gives the population health team even more information, how to help the patient. So right now, when somebody screens positive and wants help, we're able to actually pull all of those names and see and keep track of those individuals over the course of a year. It takes about a year for those individuals to fall off. So any questions about registry, because this is a frustrating tool, but it's an amazing tool at the same time. It's frustrating to build, but like once it's working properly, like it's really, really helpful. And I would encourage anybody who's in like an ambulatory setting or you have access to something like this, obviously every EMR is different. Take the time to build this because this will help you track your patients and it will help you be able to kind of prove the work that you're doing.
Okay, and Melissa, Becky's got her hand up, so.
Okay.
Hi,
Go ahead.
Melissa. Becky Betts. I'm really enjoying your presentation. Such a nice
Thank
job.
you. I talk a lot and I talk fast and it's already been
No.
40 minutes and I still have slides.
Well,
You're doing great.
it's fantastic. You are doing a marvelous job. Question I had, and forgive if you've already mentioned, and I'm having some tech difficulties, including a faulty camera today. But you guys, if I understood correctly, you left the prepare behind because of the burdensome time and constraints with that instrument. Did you replace it with another SNS screening tool or made your own? And how does it feed into the registry?
So a little bit of a background. So we're not doing the prepare form anymore. We worked with our acute care side who had, and if Minnie's on the call, she might be able to give more details about this, but acute care had regulatory SDOH screening that needed to be put into the EMR. And we wanted to work with them and actually ended up liking it better. We wanted to utilize the same because we eventually want to get referrals from ER and inpatient too. So if we're using the same EMR and we're using the same questions and a patient says yes to one of those, then it pops up on our registry and we can work with ER to identify what the patient needs and we can outreach to them. So it allows us to capture not only patients that come into the clinic, but patients that also come into the hospital system.
Awesome. And you guys remind me you're on Meditech?
Yes, Expanse.
Okay. All right. Thank you.
Kim, we just talked about that yesterday too. I didn't know if you had anything you wanted to add to Melissa's explanation. Kim Emery.
Now, everything is exactly how it is. And yes, we are using this across the whole hospital system so that we can capture this information.
I think that's part of the problem solving of like, oh, wait a second, you know, we're working on something in clinics, even though we're a small organization, Columbia County. And it's just like, what? Oh, that's what acute care is doing? I didn't know that. So the hospital is screening this way. Where's that going? And we're screening this way, even in a really small organization. So it's a really good example of problem solving and bringing everyone together so that you're getting a consistent, that's a perfect example of what you set out to do, was to streamline the process, Melissa.
And you know, you say it's a perfect example of streamlining the process. And then I'm going to sit here and I'm going to tell you that like we streamlined it and then it broke. And then we had to fix it again, you know? So it's constantly like if there's an EMR update or if there's something like that, like we constantly have to monitor the data that we're looking at because it may not be right. Something may have happened on the back end with the EMR. And then we have to go back to the table and say, can you fix this? Can you do this? So when I talk about like that 6-month time span or, you know, whatever it may be, it's a lot of it is doing that. Like, hey, this worked yesterday, but it doesn't work today. And really staying on your toes and remembering what it's supposed to look like and how it's supposed to function. Because I'll tell you that this is one of like maybe 20 plus registries that we have. So, and they're all formatted a little bit differently. But for this purpose, we're going to talk about this one. So that's a little bit about registries. And then we're going to talk about Z codes. So I know not a lot of people want to talk about coding, but what I've learned in my 6 years here is that coding is vitally important in proving what we're doing, especially to CMS and to insurance companies. And so at the beginning of this presentation, I talked about, or I guess I didn't really talk about, but I just commented that our mission is to see people as human beings, not just a number. And now you're going to say, but now you're talking about numbers. And I am, but I'm talking about it in a way that helps us to prove the hard work that we're doing so that we can hopefully get reimbursed for that work so that we can continue to care for people and we can make this sustainable. So while that is a pie in the sky, kind of a dream to make population health sustainable, one of my goals is to make it as sustainable as possible. Z codes are codes that we report under like billing and coding, even though we don't get reimbursed for them, but they're codes that we send to CMS that say that tell them what we're addressing with the patient. So you can see here in this screenshot, we have the screening tool where patients have, or a fake patient has answered yes or no to any of those questions. And right underneath that, we have created an area for the provider not only to see the questions answered, but also to select that Z code right there in the chart. So very quickly, they can see that in the past 12 months, this patient has gone without electric, gas, oil, or water in the home. So we know that we can connect that to the material hardship or utilities. And all the provider has to do is click that bubble right there, and that adds it to the to the bottom of the chart under the diagnosis code. So it adds it to the chart and adds it to the patient's problem list so that it can be tracked. This patient would also have food insecurity, so Z59.41, and then obviously the patient said, yes, I want help with one of these. So a referral would be initiated by the provider to the community health or the population health team. So this was something that we had to build into the EMR as well. We know that right now, Medicare will cover, under the G5011 code, they will cover community health time. Reimbursement is approximately $70 for 60 minutes of time. So it's not sustainable reimbursement. We also know that Medicaid is going to start reimbursing for some of these codes starting in July. Fingers crossed that doesn't get pushed back. And I'm not an expert on that reimbursement yet, but we are working on trying to make that sustainable as far as our community health worker time. But this is how we're going to track. This is how we're going to be able to say, this year we addressed this many food insecurity codes. This year we addressed this many housing instability code. And so it's a way for us to be able to get those numbers for CMS or for Medicaid or for Humana or for, whoever it may be. The list goes on and on, right? To prove that this is the hard work that we're doing, and that it counts for something a lot more than what we're currently given credit for. And for anyone else doing some of this work, you know how hard it is to get reimbursed for these things.
Well, I have to comment. So it's so rare to see one be this far along in a process to actually have incorporated dropping Z codes along with a needed diagnosis code. So that's commendable, one, but it just makes me dream. It's like, even though you're not seeing money that's going to sustain the program, to me, I'm like, how at least it gets some data in there so that you might be able to prove here's this patient who had this many hospitalizations and this many emergency department visits for a year prior to meeting with our population health team. And mobile integrated healthcare, you're hearing the same conversation that we have together. And it's like, then when you see these codes drop, you can say, oh, so these were addressed in this time frame, and then 12 months post, what? There's less hospitalizations, there's less emergency department visits. So it paves a road that we may be able to demonstrate with data and improvement in outcomes, which is the hardest and trickiest business there is. So I commend you guys for starting down the path of building it into your EMR so that your provider has an opportunity to say, hey, this is impacting overall health. I'm going to, drop this code, and now the Z code is what specifically the social determinant was. So it could demonstrate really the return on investment that hopefully we would see one day for population and health teams, and maybe even someday mobile integrated healthcare too. So
yeah. And I think it's also fair to say too, just on an operational side, making this as easy as possible for the provider is one of the biggest parts of this. So this is all right in the EMR, right above the HPI where they have to document, and the medical assistant notifies them, hey, they're positive on the screening tool or on these screening questions, similar to what they do for PHQ-9 and GAD-7. But it's important that we don't make it complicated. So the referral is like a population health referral. Our population health team figures out the rest. They don't have to say, that this is only for community health worker, only for chronic care management, or only for palliative care. It's just population health across the board. One referral, the same thing every time, and we figure out the rest on the back end. So making it as easy as possible for that provider, I think, is instrumental in the success, and you're going to see some numbers here in a minute. So, but that's a little bit about Z codes. And then I just wanted to kind of review the positives. So the things that we knew we had in our corner, the population health team, again, instant buy-in. They were like, yes, whatever we need to do to help our community, let's do it. They're already in the field. They already have extensive, whether they know it or not, they already have extensive SDOH knowledge. They're already addressing these needs without even necessarily documenting them, without even necessarily noticing that they're addressing these issues. And so it's important that with this kind of dialogue with the team, that they are able to recognize the hard work that they do. And I think that this is kind of spurred a little bit of momentum in them to be like, yeah, we do that. Yeah, we do that. And that's important for not only team dynamics, but, just that validation that they work so hard in the field. And then having the ally of the provider champion on that team has, for me, I won't get emotional, but this project was so hard. And it took so long. And, I work full time, single mom, in a master's program. I'm crazy. super crazy. So having her as my ally and my resource and the one that could like pick up the pieces where I couldn't, like I didn't know how to get there, she was instrumental in helping me with that. So I made it through that part without super crying, so that's great. And then the buy-in from our clinical team, they're already familiar with a screening tool, right? So they had done the prepare form. No one liked it. The team didn't like it. They didn't like the pushback from the patients. It was cumbersome. It took forever to enter into the EMR. But so this to them was like, oh, great, only like 7 or 8 questions. Perfect. Let's do it, you know? Because we had a workflow implemented for the prepare form in some form, even though it was through a different EMR, we really already had kind of a basic outline for our workflow, but we just kind of had to dial it in a little bit. And so that was fairly easy. And that really also feeds into my last bullet here, which is minimal workflow change on the front end. So front end meaning our patient service representatives. It was, yes, it's one more form that they have to hand out to the patient, but it doesn't really impact their flow as far as speed in getting patients checked in. So those were kind of our positives. Lessons learned. So these are kind of our wins and challenges. These are the fun slides, right? These are the slides that like make us want to put off fireworks, or at least maybe me. We had a 90% success rate screening patients for SDOH in the first week. I am very proud to say that I do monitor, I do random audits every week, and we maintain a 90 to 95% success rate for screening patients in both clinics right now. 100% success rate with appropriate provider referrals to the community health worker team. So if a patient says, yes, I want help, all of those patients that have answered that question, we've been able to track in the registry, and all of those have had a successful referral from their provider. We continue to have conversations with Greater Health Now for the community hub enrollment. It's not really enrollment, it's just participation. We've had great team buy-in, and while this appears chaotic, because as I talk to all of you, I'm like, oh my gosh, we've done so much, and it just seems like insane. It was fairly organized, and we were able to train appropriately and educate, and I think that the training and education continues, right? Because as we learn more, we get to share more. So overall, I felt like it was a really successful launch, especially for the amount of work that went into it. The challenges, obviously, I already talked about the EMR failure, how we think we have it figured out and then something goes wrong. Lack of referral system for community resources. I realized really fast during this process that it's unrealistic to expect every community resource to have some kind of a referral process, whether that's a piece of paper faxed or whether that's a phone call made by a community health worker. It's not there's no way to organize it well enough, quickly enough. It would take a very long time. And for the purpose of this project, very quickly we realized that like having that community health worker as that in between, that go between, was instrumental in getting patients connected and then following up with them to ensure that they had either gotten what they need or gotten an answer that helped us either connect them to somebody else or you know, whatever that may be. And then this was a really heavy pull for the population health team. This is not a negative. They're used to this, right? But I want to acknowledge them because they're doing all of that heavy lifting with our patients. They're seeing a different type of patient. They're addressing different needs that we haven't addressed for a while or ever, because we didn't know about them until we started screening like this. So it's important to acknowledge their efforts and that they have worked really hard to make this happen for us. And then I talked a little bit about billing. This is I hate this bullet, the insecure sustainability. You know, it's frustrating that reimbursement is lacking in the way that it is. And I don't think that this bullet is going to be deleted out of my presentation anytime soon. But we're going to keep trying. And then the literature studies might be right. So in doing a lot of research, I only have 5 minutes left. Okay, I'm gonna leave that one off because I want to talk about my data. Sorry. Okay, so progress since April 10th, 2025. We have done 713 SDOH screenings and we've had 37 referrals. This is a way bigger number than I thought it was going to be initially. And a lot of our referrals came pretty quickly. I think we had like 12 in the first couple of weeks. So they've dropped off a little, but that's because a lot of these patients have come back in now. And so we've already screened them. And if they screen negative, then we're not going to screen them again for another year. If they screen positive and they're being it's being addressed by our population health team, we're not going to address that again. So I anticipate that this will kind of wax and wane throughout the year. And then here is just a breakdown in percentage of the positive screenings that we've received. So you can see that our number 1 and number 2 are pretty close. So we have housing and transportation. Those are our top 2 needs, which I mentioned housing in the beginning. So understandable that housing would be one of our top needs because we don't have a resource to send them to. So that's just some interesting facts there. And then I'll end before noon. Thank you for listening to my whole hour. Any questions?
Really want to commend you, Melissa, on this presentation and the work for the whole team at Columbia County Health System. Is there any question that anybody has that they would like to ask Melissa? I know we're short on time.
Laurel, this is Becky again, and I don't have a question. I just want to really tip my hat, if I were wearing one, to Columbia County Health System. There's such a leadership crisis in healthcare, and we can't change without changing, and no one seems to want to change. But I always think about those mighty players up in Dayton and Columbia County, and you're doing it right. You just really have the courage to lead this healthcare revolution that we need. So continue the good work, and it's awesome just to witness what you achieve and do every day.
Thank you.
But all of you get to meet with me monthly. So if you have questions and I can help connect you to Melissa or someone else on the team, think of those questions and I can help connect you to Melissa and let you guys discuss them together. But I am grateful for Melissa for being willing to do this presentation. Really wonderful. And I appreciate it so much. Thank you.
Thank you.